State Board of Pharmacy meeting. I understand that there is a lot of concern about some of the travel arrangements getting back into Southern California. There's been some flights that will be closed. So we'll do his best to get through today so that people can catch their flights home. If there's anybody that specifically has a flight concern, let us know and we'll try to move things around. I'll call the meeting to order. We'll start out by roll call. Do you want to start, Valerie?
Valerie Munoz, public member.
Lavanza Butler, professional member.
Victor Law, professional member.
Amy Gutierrez, professional member.
Debbie Veal, professional member.
Ricardo Sanchez, public member.
Alan Chad, professional member.
Greg Lippy, public member.
Okay, the second item is public comments for items not on the agenda or agenda items for future meetings. Are there any public comments? Good morning, Lauren. Good morning.
Say that tomorrow when you're still here.
I should get home. I shouldn't have a problem.
Oh.
Yeah, I don't have a problem. Good morning, members of the board, Executive Director Harold. My name is Lauren Burton. I'm here today on behalf of Omnicare, which is a CVS Health company. And I appreciate the opportunity to provide some quick public comment to you today. I'm also here with my colleague, Charlie Harding, who I'll let him introduce himself when he begins. We've chosen to take this time to provide this public comment regarding ADDS, or Automated Drug Delivery System, because we're not an ADDS vendor, and we didn't want to detract from the agenda items today, which appears to be limited to vendors and some technical components. So we're here today to talk very quickly about the professional practice components of the ADDS and request some needed clarification from the California Board of Pharmacy regarding its statutory authority. As the board takes this issue up later today, we ask and request that each of you continue to carefully consider the language of implementing statutes, the practical implications of long-term care, and the vendor capabilities. So in particular, I'm talking about California Business and Professions Code 4105.5 and California Health and Safety Code 1261.6G. CVS Health fully supports the use of ADDS, and we believe that these machines provide critical medications to a fragile and highly acute patient population in needed rural areas. More specifically, the ADDS helps long-term care pharmacies comply with applicable California Department of Health regulations, which require emergency or stat medications to be available within either 1 to 4 hours, depending on the situation, comport with best pharmacy practices, enhance patient care, and prevent diversion of prescription medications.
Good morning, members of the board and Executive Director Harold. Thank you for letting us provide public comments today. My name is Charlie Hardig, and I am a Senior Legal Counsel with CVS. We just also wanted to walk through briefly the other reasons that we're here. Namely, as discussed in the Enforcement and Compounding Committee meeting on January 4th, I know that the committee discussed nurse replenishment, and it also discussed replenishment in terms of technician restocking or replenishment of the ADDs. By way of background, at CVS Health, understanding that committee opined and agreed that pharmacy technicians and employees could replenish the ADDs, and that this meeting was called to discuss, among other things, replenishment by long-term care facility or healthcare professionals other than pharmacists and pharmacy employees. As such, we would request, as the board and its members go through reviewing the technical components of these vendors, we ask that we respectfully request the board memorialize in writing the committee's recommendation that allows pharmacy employees to restock the machines, so long as the pharmacist is aware of the replenishment activity. I believe that was stated and agreed on in the committee meeting, but we still haven't seen that in the meeting minutes reflected, and also we haven't seen that in any board guidance. So as we move forward, we would respectfully request that. In addition, we urge the board to carefully review and consider the statutory authority through both 1261 and 4105 regarding facility personnel replenishment as permitted by the statute. I've provided a handout which includes the statutory authority under 1261.6. In each component of that, first the technology thresholds, And then the sections 1, 2, and 3, which outline respectively the pharmacy tasks in section 1, the delivery task components in section 2, and the facility and replenishment tasks in section 3. We believe that nurse restocking is supported, and many of these vendors will come up today to discuss that, and I know that is one component of the presentations. But we believe that for essentially for 3 or 4 reasons. First is I think the statute supports it. Second, I think that multiple statutory and regulatory authorizations allow licensed healthcare professionals such as nurses, doctors, nurse practitioners, and other licensed individuals to administer and handle medication. In addition, ADDs are not traditional tackle boxes. They're much more secure. They have auditable logs, and pharmacies have in place chain of custody procedures and records to help manage and ensure the security of these machines. Simply put, these aren't apples to oranges comparisons. So it would be incorrect to treat a traditional emergency kit like a tackle box. And when we say a tackle box, we really mean a tackle box picked up at your retail site that is tamper evident and had a seal on it. These are much more sophisticated machines with much higher capabilities. In addition, we don't believe that limiting the replenishment to pharmacy employees inherently makes the ADDS more secure or less secure. The statute itself discusses the removable pockets and drawers. Other auditable records and logs are required in most of these machines. And the pharmacies implement a number of measures they put in place to help prevent diversion, reduce errors while restocking these machines, like barcode scanning. Again, we would request you carefully consider that while you're discussing it with each vendor here today. And finally, I just want to point out that half of all states do allow nurse or nurse restocking capabilities or possibly facility personnel capabilities. Of the other half of the states, about a quarter of them have not opined on this issue, and then another quarter have specifically only allowed pharmacy or pharmacy employees to restock. So in full transparency, I just wanted to point out that right now, about half of the states in the country and the boards of pharmacy do allow nurses and facility personnel to restock. That's all the comments we have today, but we really look forward to working with you and your staff, and please let us know if there's anything we can provide with regards to the ADDS and professional pharmacy practice component, or any questions that you may have. We're certainly happy to provide any assistance we can.
And Laura, can I ask you, since this is kind of with the agenda, but it isn't really, is it okay for us to discuss this, or is this a specific item that we need to agendize? Because they're basically a user of the ADDS, and they're restocking, so they're from the pharmacy perspective. They're trying to give an opinion, just an overall statements on ADDS use from a pharmacy perspective. I just want to make sure we're...
So under item 6, there is a discussion of current and potential circumstances under which ADDS are used and the impact on public safety. So I think you could probably, if it fits into that,
just discuss it then. Are you guys going to be around then?
Under that?
We'll be here. We apologize for having this in public comment, but we didn't think it was appropriate to have this conversation with the vendor conversation.
Because I actually do have a lot of questions about this, but I'll wait until we get to agenda item 6 to do that. Okay.
Thank you.
Thank you. Any other public comment? Okay, we'll move on to item 4, which is discussion and consideration of the proposed regulation to add Title 16 CCR, Section 1746.5, related to travel medications. At the June 2015 board meeting, the board approved a text to add the travel medication regs that are before you. On April 27, 2016, following a 45-day comment period and 2 15-day comment periods, the board adopted the regulation language and delegated to the executive officer the authority to make technical or non-substantive changes as required by OAL. Just moving on, I think the rest of the summary is in your handout. At this meeting, the board will have the opportunity to discuss the regulation and determine what course of action it wishes to pursue. Among the options are 1, amend the regulation to address any concerns raised by stakeholders, or 2, adopt the regulation as approved by the board January 24th, 2017. Now, on here, there are some, and Jenny, is there any particular comments from the staff that we need to review on this item? Or are we ready to go, we believe?
I think the modifications that we have will allow the rulemaking to be completed successfully, and I would encourage the board's aye vote on them. One of them was a relatively technical thing. When we changed the requirements for the immunizations, we neglected to change the immunization requirement here on the travel meds as well.
Is that the only?
That was the 14 days.
Laura?
Correct. That was the primary issue.
The reason for the 14 days?
Yes.
The reason for the additional
Consistent.
15-day notice
Okay.
was the inconsistency.
So do you
between-
need a motion?
Yes.
So moved.
Second.
Yes.
Yes. Oh, is there an attachment for comments? Okay. So it's a green. So we received just one comment. It sounds like it's a question,
Yeah.
not really a comment. I think it's a clarification. The law says furnished, but my understanding is that I can consult the patient. Does not have to be obligated to be filled at the pharmacy. So I'm not sure this is really a comment.
I think it's a comment on process, not on the regulation itself.
Okay. All right, so we have a motion and we have a second. Victor? Okay, any board comment, member comments? Public comment? Come on up, please. Can you, turn up the mic? Oh, you're having is it me or just the,
Dan, who can you not hear?
Who can you not hear?
Really?
Okay.
Wow.
Can we turn up the volume? Okay. All right. Any public comments on the travel medications reg? All right, all board members in favor, raise your hand. All right.
So before you move on, I would recommend that you also authorize, sorry, it's around my computer.
Right.
I would recommend that you also authorize your executive officer to make any non-substantive or technical changes that
moved.
may be required to complete the
Second.
rulemaking file.
Okay, which is our
So the rest of
standard
it.
executive officer clause that we put on all of our motions. Okay. So Greg, motion, Victor, second. All in favor? I'm sorry, public comment. All in favor? Okay, moving on to item 5, which is discussion and consideration of the proposed regulation to amend Title 16 CCR, Section 1760 related to disciplinary guidelines. So Anne, do you want to walk us through this? I know this is your area of expertise and you've been working very hard on this.
Not sure about area. Okay,
I know the board approved the language. It went over to OAL.
At the January board. At the January board meeting, board members were advised that OAL was disapproving the rulemaking specific to the disciplinary guidelines. In the board materials is the letter from OAL that is documenting the basis for the disapproval. And included in that memo is also staff's suggested fixes for those various items that were specifically called out. We did have the opportunity to speak with OAL last week. We were only able to speak specific to the language, and we have not received comments back yet to the proposed changes to the language from OAL, but we're bringing it before the board because we have a bit of a timing issue. So what you should have received was a copy of the language itself. We put within the memo, the cover memo, those items that were very specifically called out in the letter. This includes substantive changes that were detailed in the memo as well as non-substantive changes. So some of the types of things that we're doing is updating the revision date because now you would be adopting, if you so choose, a new date. The areas of concern that were brought forward, one is specific to reporting to the board. We had added in a form or format, and because OAL determined that did not meet the clarity standard because we didn't specifically state what that form or format could be. So we're recommending to remove that. With the drug testing, there was an issue. We were using the term geographic area that we have used historically. We've used it in prior versions of the disciplinary guidelines. They felt that was ambiguous with that term because we had not used it in that context, in that term before. So we have changed that term and tried to write around it so that it gets more closely at the intent, which is if someone's required to do drug and alcohol testing as a term and condition, if they go somewhere where testing is not available by the current vendor, they need to find and get approved by the board another vendor. So that's what that one is. And then with respect to term, I think it's 23, the Pharmacist Recovery Program, when we made all of the changes, we moved language from one area specific to the cost associated to earlier on in the term. And so we had to show it being moved from one area to another area. So that's what term number 23 is. If I can just stop and ask if the board has any questions on any of what's been brought before, I'm happy to answer them.
So are there any items in here, just from your perspective, our staff perspective, that there's concerns from a substantive, are you in agreement with all of these changes?
So I think that to address the concerns raised by OAL, we are offering these changes to address their concerns.
Okay.
But it doesn't cause any additional concern.
I think that we are able to continue to maintain the policy behind what we were trying to effectuate with different words.
I think Josh wants to say something.
Well, I'm not sure I should. I think the most politic way to say this is that everyone was surprised by the nature and quantity of the comments from OAL, which are, in my experience, are unprecedented.
Definitely the quantity.
And the sort of type and the nitpicky nature of them. So I think, as Ann said, we haven't yet heard back from OAL with regard to the changes that we've proposed. So we just don't have a great deal of confidence, as we never would have expected that rejection in the first place. So it's hard to know whether these will be enough to satisfy the person who will make that decision.
By doing this, we don't need another comment period, do we?
We will need another comment period because some of them are substantive. The one that really is substantive, I believe, is the drug and alcohol testing one, where we've removed the geographic and restated how it should be working. So I do believe that that one is substantive. Both Laura and I have been working on this, and I think we're in agreement that that one is, but since we have to do the 15-day, we'll put in all of these non-substantives.
Well, can we find out if they're going to accept it before we go through the comment period so we don't have to go through a second one?
We can ask whether or not it wouldn't necessarily be binding because it may trigger other things. I mean, we just go into this with good faith. We listen to what the objections are, and we move forward with what we think we need to do in order to resolve the problems.
So, Ann, you said that you have already provided them with the changes that are here. We just haven't heard back.
Correct.
And the main changes that we did are the reds.
Yes, the reds are the only new changes that are being done. And like I said, some are substantive, which is why we need to do the 15-day. I believe that the drug and alcohol one is substantive. But a lot of the other ones are non-substantive and could have just been handled if we didn't have the substantive change to be done.
So do we need a motion then to?
Yes.
So can I make a motion, and what is?
I think, can I ask Laura, how should this motion be made?
Yeah, I was just going to ask her for the wording.
Good. So I think we should do it as you would do a standard motion and authorize the changes that you have in front of you. And then also, assuming that there are no negative comments, authorize the executive officer to sort of proceed with the rulemaking file. And then you can make a third motion, or that could be one motion, and then make a second motion that would, in the event that we receive further comments, as long as we direct the EO to have the authority to make changes that are consistent with the policies set forth by the board, so that she can make substantive changes consistent with your policy, do a 15-day notice, and that would have to come back to you.
So can we make that all one motion, or you don't think so?
I think I would do it in two motions to make it clearer. So the first motion would be to approve the modified text that you have in front of you. and basically send it out for a 15-day notice, and then, assuming no negative comments, authorize the executive officer to finalize the rulemaking package and make any
Motion to approve the
non-substantive
text
changes.
and send it out for the 15-day comment
I think
period.
Debbie was in the process of
I
doing
was
that.
doing that, I had just asked her to.
I'll do the
clarify.
second.
You have to hear the motion first, right?
But I do
gonna be.
appreciate the confidence.
I know what it's going to be.
Okay, so Debbie, you're making that motion that
Yeah. And do I have someone to second?
Greg seconded it.
That's okay. Cheryl.
Okay,
go
Cheryl?
ahead. Go ahead.
All right, Cheryl.
I second.
Any board member comments? Public comment? All in favor? Okay, so there's a second motion that needs to be made.
Right, and so for that motion, and this would be in the event that OAL directs something that OAL would deem as a substantive comment, that you authorize your executive officer to make substantive edits that are consistent with the policies set forth by the board in the document that you have, and along with the discussions that have taken place. And then if that occurs, she would basically issue the amended text for a 15-day notice, and it would come back to the board with all the comments at a subsequent board meeting, and then for final review.
Okay, motion on this.
Can I second it, Greg?
Greg, motion?
So moved.
Debbie, your second?
Yeah.
Okay.
No, Cheryl wanted the second.
Any board member comments?
I
Public
second.
comment? All in favor? Okay, moving on. Agenda item 6, which is automated drug delivery systems, which is probably why most people are here. Business and Professions Code, Section 4186, Health and Safety Code, Section 1261.6, and other statutes set specific requirements for pharmacies that operate automated drug delivery systems, or as we call ADDS, devices in licensed health facilities. Among the requirements, these devices must collect, control, and maintain all transaction information to accurately track the movement of drugs in and out of the system for security, accuracy, and accountability. There are key provisions that are specified that states who is responsible for stocking this device with medication and how restocking may be done outside of the health facility. As many of the devices, as technology's changed over time, our regulations is probably not kept up with the device changes or the technology changes. So the board has decided to invite vendors to present information about technological features that are available and how the devices are affected by the existing statutes that were described just now. The board is interested in seeking ways to allow pharmacies to provide better quality care and access to patients while ensuring that security and control of drugs is maintained specifically for diversion of controlled substances and other prescription drugs. The board has received interest from a variety of vendors who have submitted questionnaires. A copy of those questionnaires are attached to the meeting materials. All the vendors were approved to be presented to the board. There is attachment 1 as a summary. Attachments 2 to 9 and 11 include all of the questionnaires and the documentation submitted. Attachment 10 includes a questionnaire submitted by a pharmacist who's unable to attend the board meeting. So I guess the first individual we have, and these are in order and they've already been specified in the agenda, and we request that each presenter keep your presentation to 15-20 minutes, allowing sufficient time for questions as well. The first one is IMG RX, MediFriend RX. Are you here? Good morning. Good, how are you?
Good morning, members of the board and board staff. I am Kevin Rue. I'm General Counsel and Chief Operating Officer of a company called IMGRX. As a little bit of background, we have established and operate 21 pharmacies in the state of California. We put those pharmacies into community clinics so that they operate as on-site pharmacies In particular, we work within the 340B program to get cheap medications to patients at these clinics, and of course to bring a pharmacist care to the point of care at those clinics. And it is within that setting that my company has developed technology that we call MediFriend RX. It's an automated prescription dispensing machine, and it is capable of we think, of bringing a pharmacist's care into even more remote locations where perhaps the patient volume is a bit too small to justify staffing with a full-time pharmacist. So remotely, we can bring a pharmacist to these locations, and remotely we can have that pharmacist control every step of the dispensing process and offer patient consultation. So it's with that background that I think my purpose here is less to sell you on the technology, because the technology, there are permissions in existing statutes for use of the technology, as you know. But my purpose, I think, is to ask you to shift some of the responsibility for that technology away from the community clinic type of user and actually to pharmacies, the pharmacies that would and can remotely operate these machines. As Amy mentioned, 4186 of the Business and Professions Code allows for certain kinds of clinics to have machines located at their facilities, and ultimately makes them responsible for security and maintenance, and ultimately the act of dispensation. There is a pharmacist involved in the process, but I think the text of the code section makes it apparent that that pharmacist is an employee or a contractor of that clinic, and therefore it's the clinic license that's ultimately responsible if anything goes wrong.
But just to describe your system, so you've got a unit of use packaging that goes from the pharmacy to the clinic, and it restocks a machine.
We stock it with unit of use packaging, yes.
And how is the product labeled?
It is labeled within the machine, remotely ordered by the pharmacist. The pharmacist is able to first verify the drug, that it's the proper drug, and then the machine applies a label, and at that point the pharmacist again reviews that label, checks with the patient to see if there's a consultation desired, and when that is through, it's the pharmacist that releases the drug to the patient.
So the patient requests the consultation?
Yes. Well, no, the pharmacist asks if the consultation is desired, yes.
So it's upon patient request?
Yes.
And how is walk us through the process. The patient walks up to the machine. Is the patient or the healthcare worker that interfaces with the machine?
Initially, what we're doing initially is taking advantage of 4186, which requires the presence of a healthcare worker. So, and let's face it, it's new technology, and it might be a bit scary to some of these patients who are coming up. So we do initially staff each machine with a pharmacy technician. That pharmacy technician is there to introduce the machine to the patient, to assist the patient in operating the machine if they like, and then because 4186 requires it, it's the technician that will remove the package from the machine and hand it to the patient.
So it's a machine. Is it just a freestanding machine that's located? Is it in a clinic?
One more time.
In a clinic?
Yes, it is in a clinic.
And the prescription, does the pharmacist review the prescription?
Absolutely.
So the prescription's faxed to the pharmacy, or?
Electronic.
It's electronic. So
yes.
It's ERX sent to the pharmacy. The pharmacy then the pharmacist can release the med remotely?
That's correct.
And the labeling is done per the input that's done by the pharmacist?
That's right.
At the pharmacy site?
That's correct.
And the technician removes it already labeled per
That's
the
correct.
pharmacist
Yes.
instructions. The machine does all the labeling.
Yes, it does.
And so the pharmacy tech just basically pulls it out of the chute or.
That's exactly
Okay, so
right.
I think I've got it. Okay.
Okay, and
Trying to
it's-
follow this through.
And it's unit of use,
Yes, it is.
one dose,
No, I'm sorry.
30 doses.
30 doses, correct. Yeah.
And so I guess by requesting, so you're asking amend 4186 to allow the operation not be under the clinic license. Is that, I'm not
yes,
reading that right?
in addition to 4186, there's 4119.1, I believe it is, that allows a pharmacy to operate an ADDS in certain kinds of facilities. Those are long-term care facilities, and
Right.
they aren't the kinds of facilities that are our clients.
Excuse me for a second. Who does the consult? When does that occur?
The pharmacist does the consult, and we have a couple of ways that it can be done. There's an audio-visual connection, telephone and screen on the machine, but at least in the beginning, since we have a technician there, that technician will have an iPad or something similar with them, and offer a Skype or telephone consultation if they wish.
Do you have controlled
Thank you.
substances stocked?
Wait, can we finish answering
Okay.
my question about 4186?
Oh, so
Because
so
it
yeah,
sounds
yes.
like is this machine going to be licensed?
We would like it to be licensed. We want it to be licensed
as a
by
pharmacy?
the pharmacy, to be under a pharmacy license. Under 4119.1, the machine may be used and operated under a pharmacy license, as I said, in long-term care facilities. At the end of that statute, it essentially says, just because the legislature named these kinds of facilities, it doesn't mean that machines cannot be used in other facilities as licensed or as permitted by the board. So 4186 or 4119.1, we would like the board to shift responsibility for operation of these types of machines away from the community clinics, which are strapped for money and resources, and to the pharmacy that operates the machine. Make the pharmacy and the pharmacy license responsible for the operation of the machine.
I was under the impression, and Laura, isn't that a requirement in our current reg on registration of remote automated drug delivery systems? They're required to, the pharmacy is required to report that to the board. Yeah, that's already in
new,
place.
And it appears, doesn't that work specifically with the long-term care facilities?
It's with any pharmacy that stocks any medication offsite.
And under 4186, let me pull the language, well, I do have it. It clearly states that the clinic is ultimately responsible for maintenance of security, and of the medications, the purity of the medications, and we would like to see again that responsibility completely shifted to the pharmacy. I might also add that not all community clinics get a license from the Board of Pharmacy. You know, they don't want to dispense medications themselves, and those under 4186 as well as 4119, those are precluded from having the benefits of this technology and of a pharmacist's care for their patients.
Oh, Ricardo, go ahead.
In case of human error, just say it's a what if,
Yep.
Can they put the medication back into the machine? Is there a way
No,
of
there's
how do you do it?
our technician is there, so, and the technician will review the bottle once again when it comes out, and so the technician will be responsible for collecting the error that occurs, but the technician does not have a way. We won't restock the drug into the machine. We would take it back to the pharmacy that operates it.
If it was by accident given the wrong medication, they would have to go back to the pharmacist?
Yeah, we would go back to the
Turn it
pharmacist.
there.
Yes.
Okay.
And who's paying for the cost of these machines? Is the clinic or the pharmacy?
The pharmacy in our situation is paying the cost of the machines.
Do you have any of these pharmacies in the LA area that maybe we could
No,
go
but
in and take
we
a
would
look?
love an introduction. So-
How many devices do you have installed statewide?
Right now, we've actually just finalized the technology. So we've had one machine that we've had in use in the Napa area, and actually we've used that machine under a different statute. It's operating under a pharmacy license because it's adjacent to our pharmacy there, and so it's operating under those limitations. But now we're ready to move it away from the pharmacist, and hopefully in the next week or two we'll have 3 operating here, and the 4th one is headed to New York City.
How are the machines restocked?
The machines are restocked by a delivery tote that comes from the drug distributor. The machine is completely locked, and the distributor punches in the code, inserts the drugs into a bag or into a cartridge, a locked cartridge.
The
Yes.
delivery individual from the wholesaler
Yes.
restocks the machine.
Puts the drugs into the machine itself. The machine is relocked, and then the machine pulls and verifies each drug and places it in it's a honeycomb pattern that we stock the drugs in. The machine knows where it places it, and then the invoice for the drugs is compared to the list that the machine produces of what it retrieved and stocked, and then the pharmacist validates that.
So the restocking does not come from the pharmacy.
The restocking is initiated and controlled by the pharmacist remotely, but the physical act of moving a pill bottle from the tote bag and onto a particular slot in the machine consider the machine the hands of the pharmacist.
Sure.
Oh, I thought I was on, sorry. You want to move these machines away from a clinic setting?
No, we want to put them into the clinic setting, but under the responsibility of the pharmacy and the pharmacy license. As I read 4186, there is a pharmacist involved who does the final dispensation, but it's not clear to me it appears to me that pharmacist is an employee of the clinic. In our case, that wouldn't be the case. The pharmacist will be employed by a licensed pharmacy.
I think
and it's that license that would be at risk if something went wrong.
My understanding from what he stated is that he wants the machine, the device tied to the pharmacy, but not require the clinic to be licensed. Is that correct?
That's part B. But I'd like it to be tied to the pharmacy license and not to the license of the clinic.
But it would be any clinic. It would only be in a clinic. This wouldn't go into, for example, a school location, in a parking lot, or somewhere else.
No.
What type of clinic? Would it be still the free clinic or community
Community
clinic?
clinics, or that's our market. That's what we're interested in.
Would it be a
sure.
licensed entity of some sort? Would there be some other regulator in the space? Or would this be like a physician's office that may be calling itself a clinic?
If the current law would require it to be a licensed facility, and if we had to work with that limitation, we would. To be honest, I hadn't considered that it could be a random doctor's office that calls itself a clinic. It's, we do have some community clinic clients that are sizable, but have simply chosen not to be in the business of dispensing medications, and they don't get a license for their facilities, and they're, like I said, they're rather sizable.
You're not opposed to the clinic being licensed by somebody else?
No.
You just want the responsibility of the machine to tie back to the pharmacy?
Correct.
That basically owns the drugs and is responsible for stocking them, and not the responsibility of that machine tied to the clinic?
That's
Because
right.
you see them as two different entities?
Yes. And those clinics, as I said, they're nonprofit entities. They're strapped for cash.
And what are the costs that they find themselves? Because I'm just trying to follow this through. Because right now, the way that I'm reading 4186, it says automated drug delivery systems may be located in any clinic licensed by the board.
Yes.
So that means the board would license them as a clinic. What are the concerns from the clinic perspective to be licensed?
That if they have gotten that license and an error occurs, because even for the clinics, as well as for the patients, it's new, it's scary technology. And they, as a practical matter, are not in control of the dispensing process. The pharmacist is. And under 4186, as I read it, that pharmacist would have to be an employee of the clinic. And once you're involved in, especially in the 340B space, once you're involved in the dispensation, then there's all of the regulatory concerns at the federal level that you have to comply with. And this is why community clinics turn to a company like mine to take the responsibility of bringing a pharmacy on site rather than having their own in-house, clinic-owned pharmacy.
I have a question, too.
Sure.
The machines, are they freestanding, or
Yes.
are they bolted, or they're freestanding?
Well, we secure them to the wall and the floor. They're quite heavy right now. The first iteration is 6 feet tall,
Okay.
and 3.5 feet wide, and about 25 inches deep. So it's
I'm just
tough to move.
Is it something you can just pick up and
No.
take off, or is it something that's bolted down and
Right.
a little bit more
It is
difficult
secure.
to take?
Yes.
Okay, I have a question. And the pharmacist is going to be at the clinic or in a pharmacy somewhere?
A pharmacy, we'll call it a pharmacy somewhere.
Okay, and possibly consulting 3 of these machines, one pharmacist, or?
Yeah, possibly. We don't want, though, to, if you will, have a pharmacist in a cube somewhere where they're just looking at screens. That's just not our business model, and operating machines. Initially anyway, we see a pharmacist working at a live
pharmacy,
yeah, and then
pharmacy.
and then having 1 or 2 machines to be responsible for.
In addition to a
In addition,
freestanding pharmacy.
right? If they can handle that, yeah.
How would the counseling take place? Because you said the patient may request counseling. So if the patient says, I want to be counseled.
Yes.
How does that happen?
Well, we do have audio-visual links on the machine. So there's a screen with a camera onto the patient, and then the patient, of course, can see the pharmacist, and a telephone to pick up. But if that doesn't feel private enough, like I said, there's a technician. At least initially, we have a technician standing there. Technician has an iPad with Skype or FaceTime, and we can offer it that way too. Or we can say the pharmacist will call you if you like, on your own cell phone.
So I'm going back to this. It sounds like currently the pharmacy is under the same umbrella as these clinics. Or are they totally two different entities?
They're 2 different entities. Our pharmacies are independently owned. They're
Okay.
independent contractors. They are simply on site. We lease space from the clinic.
And then in 4186C, it says the stocking of an automated delivery system shall be performed by a pharmacist. So what you described, I'm not sure exactly, the delivery guy puts it in the machine moves it, and the pharmacist kind of looks at it, I guess, remotely.
So the machine pulls each package within the delivery. The pharmacist checks it real time, makes sure that if it's, it is what it says it is. It's got the barcode. We've got a camera, and then the pharmacist says, "Yep, that's that puts and it puts it into a slot." And then there's a list that's produced, and the pharmacist can compare that list to the drug invoice.
What if there's an error and the wrong medication shipped by the wholesaler?
Then that medication would be put into a holding bin for retrieval later, but it wouldn't be dispensed.
A holding bin inside the the automation?
Mm-hmm.
Now, I'm a little confused here. I think we all are. Now,
Okay.
Hi, Josh.
Oh, sorry.
No, go ahead. Go ahead first.
Okay. The drug delivery. Okay, it doesn't come in a cassette that's filled by a manufacturer. Is it, filled by the wholesaler.
No, we're
okay.
I know that technology occupied a lot of the last meeting in July, but no, we're not talking about that.
So this comes in a bottle, or this is a unit?
It's the same. It's the same as the drug delivery to a to a pharmacy site. The drug distributor typically brings in a tote bag. What's different, and it is that the contents of that tote bag are placed into a locked compartment within the machine, and then those are retrieved and validated from within that locked compartment.
Okay, but see now, and I'm having trouble understanding how they're taken from the bottle and dispensed to the patient.
Unit of use.
We're doing the flat unit dose packs.
So the 30 if your prescription is a 30-day prescription, there's 30 pills within each bottle.
Oh, okay.
Kevin.
Josh, did you have something you wanted to say?
Yeah.
Well, I just wanted to try and frame the discussion. As I understand the request, I think there are at least 3 and potentially 4 statutory changes that might be required in order to accomplish what is being asked for here. Number 1, and it's not all of these are of equal weight in the presentation he's given. So, but number 1 would be, it appears that he's asking for to allow ADDS to be in facilities that are not licensed clinics or clinics licensed by the board. So that would require a change to 4186A. It appears he's also asking for a change, or at least a loosening of interpretation of 4186C, which requires that stocking be done by a pharmacist to allow for wholesaler or other conveyance physically that's then supervised remotely by a pharmacist in terms of video screen and so forth. Number 3 seems to be requesting a modification to D to take away the requirement that the clinic exercise some supervision and control over the machine and place that responsibility exclusively on the pharmacy. And then the 4th, and you can confirm or deny this.
Yes.
The 4th may be that I'm not clear whether all of your possible client clinics would meet the requirements of 4180, whether you are also hoping to expand the kinds of clinics that can, if they choose, seek licensure by the board under 4180.
So if I were considering the 4 things that you said, I would call A and D the least important. Those are things that would be nice to have, that we can actually expand the use into facilities that are not currently licensed as clinics. The most important would be the change that shifts the responsibility for the operation of the machine, the maintenance and security and all of that, from the clinic to the pharmacy license. And frankly, I don't, if that happens, then I think the logic for requiring the machine to be placed in a licensed clinic goes away. But again, it's the first thing that's most important to us is that we want to be responsible, ultimately responsible for the operation of the machine. And as far as the stocking question goes, you know, I would support what we heard earlier in the public comments from CVS, and to consider that others can operate under the supervision of the pharmacist, and I'll look forward to that part of the discussion later on.
And then one other, I just wanted to clarify for the board to make sure everyone understood what's being asked here. The other part of your presentation was a statement or maybe an implication that without requiring a statutory change, that perhaps the board might be able to authorize this by way of 4119.1.
I think there's regulatory room there. Of course, that's for your office to help determine.
Laura and I just want to say that Laura and I are unanimous in our opinion that that this would require a statutory change, and that that's not the intention of 4119.1E in terms of allowing circumvention of 4186.
Okay.
And I would also add to that I think in the written materials that were submitted, I think there's reference to a study. Yeah. And I think to the extent that there seems to be a request for a study,
we submitted those written materials last month, and we do intend to perform a study of the use of our machines. You know, I think we're going to keep that for our own use.
Okay. I just wanted to be...
We've changed tactics a little bit.
Okay. Well, I wanted to make it clear for the board members that because the board does have a provision in its regulations that allows it to sort of waive regulatory requirements. Here we're talking about statutory requirements, and that is only under very strict, limited circumstances in conjunction with a university or a college of pharmacy, and I don't think that...
We
when
had
you're
that
talking
part
about waiving statutory requirements, it doesn't work.
We actually are going to involve the University of San Francisco in our study, but that's again
different.
Our tactic has changed.
And there's nothing wrong with that. I guess what I'm saying, it's not one that would fit under that. Similar to I think you've heard regularly about that UCSD study. It's not that. It wouldn't. Because the statutory, it's in the Business and Professions Code. It's not in the California Code of Regulations, so it's not subject to that provision within the board's regulations.
A couple of things that concern me about this model is the restocking. I mean, right now we require pharmacists to sign any wholesaler delivery orders, knowing that they're not always accurate. I mean, there are issues with wholesalers, and typically the wholesalers hire someone else to do the delivery for them. They don't usually hire a courier service to do it. So you're essentially having couriers restocking your machine. That's the first one.
Well,
and the second concern I have is, why are the clinics so concerned about one of the requirements that we have licensed automated devices inside licensed clinics is to have the quarterly review that is done by a pharmacist who goes out there, checks and sees how the machine's working, how are the patients being cared for, and gives a report to the clinic that identifies them of any gaps in some of their regulatory standards. And why a clinic finds that, I mean, I would assume the pharmacy would do that as part of their services to that clinic.
Well,
I have a hard time understanding what the cost implications are for a clinic permit.
I can tell you that the clinics tell me that they are nervous about, you know, if they have obtained a license, they are afraid to expose that license to new technology. Again, 4186, it does involve, you know, this quarterly review by a pharmacist, but you know, all of these clinics have consulting pharmacists, but it's not that. It doesn't appear that it's that pharmacist's license that is on the line for the operation of the machines, and that's what we want to achieve. We think it helps patient care as well.
And I guess the way you know, the information you provided is a little bit different than maybe the others and what we were anticipating, because we had that list of questions, and So maybe you
Yeah.
sent it in before you saw the list of questions.
Yeah.
But so I think we hit how the pharmacist reviews the order because you said it's electronic.
Yes.
But so does the pharmacist have access to, prospective and retrospective review of the medication? So, patient profile?
Yes.
And that's assuming that the patient repeatedly goes to that same clinic, I'm assuming.
Yes. We work within the 340B program, and under that program, these clinics receive a steep discount on the purchase.
Right.
And those medications can then only be dispensed to what are called eligible patients. And eligible patients are the definition includes a regular patient of that clinic, if you will, who's come in the normal course of treatment, and the prescription is written by a provider at that clinic.
Okay.
So we have, because of our pharmacy and our relationship to the clinics, unlike an off-site pharmacy, we have access to the clinic's electronic health records. And so the review that the pharmacist does when the patient identifies themselves at the machine is exactly the same as the review that a pharmacist does when a patient identifies themselves at the pharmacy window.
Okay, and then kind of going back to the question I think Ricardo asked about, the potential handing out the wrong medication. So we'll assume the machine did everything right.
Mm-hmm.
But so that's kind of, I think, the focus of question 3 is how do you make sure that the right medication is removed and provided to the right patient?
In our case, it's proprietary technology, but it's barcodes and it's actual cameras within the machine that present the medication as it's pulled and to the pharmacist.
And I think you said you have one machine in Napa right now. Have you had any errors?
No.
I think we're running to the end of time. If we can move on to, we've got a number of other presenters that are coming afterwards.
Yeah.
Thank you for coming out.
Thank you.
Just one more question, Kevin. Do you right here? Does the company have a website or you have a video that could illustrate how all these functions work?
We of course have websites. We don't
You'd have a
go
video
through
that
the
would
technology on the website. The proprietary information about the stocking, but I'd be happy to talk to you about it anytime.
We can go visit Napa.
Yes.
And so
in fact, there's an article appearing in a Napa area newspaper. They called me.
So you would envision selling this to like an independent pharmacist or a pharmacy chain, whatever, that would want to service.
We are a pharmacy
Okay.
chains, if you will. So
you go to clinics and this is a solution for them?
Yeah, that's correct. In the state of California right now, we have 21, and then we have, we're a startup company. We're only 3 years old, but we also have 2 pharmacies now in Virginia, 1 in Missouri, and hopefully a few in Oregon opening up soon.
And
has HRSA approved this technology? I mean, this use, because you're basically merging a contract pharmacy with a clinic permit. I mean, with a clinic. So just interesting as to HRSA's take on this.
We haven't had any issues with HRSA. We register the clinic site as a delivery site for the 340B medications.
But once you move it to the pharmacy, that becomes a contract pharmacy.
But our pharmacy, our contract pharmacy is still the same. It's just that the contract pharmacy is now operating the machine at the other location as well. But yes, we are a contract pharmacy, and we operate well within that framework.
I just wanted to ask, how many clinics approximately are being served by these 21 pharmacies in California? Is it one? It's not one clinic per pharmacy, I assume?
Yes, it is.
Oh, it is. Okay.
Yeah. But with the help of a machine, we'll be able to expand that number.
So you're doing the 21 without the machine, and you want to
Yes.
bring in the machine.
Right.
So that's the contract pharmacy relationships you've established for your 21 locations.
The 21 pharmacies that we currently operate all have a contract pharmacy relationship with the clinic, which may be a single clinic or it may be a group of 3, 4, 6 clinics. Each of the on-site pharmacies has a contract pharmacy relationship.
You have all of those devices registered with us currently under 4105.5?
They're not registered yet because we're just hoping to deliver them in the next week or two.
Oh, I'm sorry. I thought you were already operating them.
No,
I misunderstood.
just the one that's been operating is the one in Napa that we're actually going to move. Yeah, yeah.
Thank you for coming.
Thank you.
Okay, we'll invite up the next, which is Cubex. Good morning.
Good morning. How are you?
Oh, we've got slides. Okay.
Good morning, Board. Thank you for giving us the opportunity this morning to speak with you about our solution to help manage eKit and First Dose. My name is Anton Visser, and I'm the president and CEO of a company called Cubex, and I have my associate here with me, Karen Nishi.
Morning.
So what we would like to discuss this morning is some topics that have already been touched on this morning, which is really how these systems are being managed today in long-term care facilities and also in institutional pharmacies. And specifically what we want to focus on is on the restock process and exchange of our systems. And that's one, and we want to address how that affects patient safety and also staff safety within the facility. So those are the key things that we wanted to review with you this morning. Before I get started, we are a partner with another company that is presenting today, and I thought it may be beneficial, and I promise to go pretty quickly through my presentation, for them to join right after we do, and that's Becton Dickinson, because we actually utilize the same hardware, and it may be helpful for you to see the two together as I go through that. So first thing I wanted to get into with you is just basically what is the key request that we have of the board. Our request is to continue to allow pharmacy personnel or a nurse to do the exchange of the medications that come in a secure tamper-evident device that we call QB. And I'll talk to you in more detail about how this device gets programmed at the pharmacy and all the security it goes through at the pharmacy level. But that's really our request, is to continue to allow that to occur in these facilities. As per the California Practice Act 1261.6. There's three different types of automation, actually 3 different ways of managing medications today in long-term care facilities that you may be familiar with. The first, all the way to the left, is the tackle box that many folks have talked about this morning. And that system has some of its inherent challenges. One, it is a manual system, and so we don't have a track record of who's going into it, when they went into it, et cetera, from an electronic standpoint. And secondly, when they do open the tackle box, of course, they have access to all the medications inside the tackle box, not just one individual medication. And thirdly, also very important to the pharmacy, is a lack of visibility for the pharmacy from an electronic standpoint, not understanding, again, who accesses it, what did they access, how many did they access, and which patient did they access it for. So that creates challenges on the pharmacy side as well. The system all the way to the left is what we refer to as remote dispensing system, and that is not part of the discussion that we want to talk to you about today, just another system that is in the market today. The one we really want to focus on with you is what we refer to as a high security medication management system, and our goal with the system is simply to help manage First Dose and eKit. So what does the system consist of? It really consists of software, a cabinet, and then what we call QB pockets. And these are tamper-evident pockets that come in a variety of different sizes that get programmed at the pharmacy. They also have a microchip on them, so it can be tracked not only at the pharmacy level, but also back at the nursing home level. So those are the components of the solution. And the benefit of the solution to the long-term care facility is the increase in patient safety and also in staff safety, making sure that the right person has the right access to the right medication within the system, and that that's all tracked electronically. The way that that happens, the user has to log into the system through BioID, identify who they are, and if they have authorization to get into the system, they'll be given authorization to get into it, unlike a tackle box. And then once they're in the system, they select the patient, and the medication that has been pre-approved for that patient will appear on the screen. They can then access that medication, the drawer steps forward, the lid for that item, which is on that pocket, pops open, and the nurse then has access to that medication that's inside of that cubie, not access to anything else at that point. The nurse would then take the item out, close the lid, and go off and take care of that particular
Can I interrupt you
patient.
and ask a question?
Yes.
So in that cubie would be potentially multiple doses of that medication.
Correct.
And so does the cubie know that only one dose has been taken out?
It does not. The cubie does not know that. So we do have the capability, depending on the type of med and the policies and procedures, to require a count back feature or a blind count, or we could also, depending on the medication, require a witness feature as well. So there's those capabilities in the system that can help facilitate complete accuracy.
You typically figure it out when you run out of a med, when you think you should have 10 there and there's not 10, that there's been an issue with someone taking out more. It eventually gets detected, just
It does.
because the restock process.
Right, it gets detected, and so you have a, I mean, obviously, there's only so many people who got into that cubie.
Exactly.
Right.
But you still don't know which one of them took potentially multiple doses.
And with controlled substances, you have, as you referred to, a blind count, so it will tell you how many tablets are in there. So if you put in, there's 8, and there really should have been 10, then it'll flag that there's a discrepancy that needs to be resolved. So it really boils down to whether it's you or the person before you, right, that caused that discrepancy.
You would do the blind count how often, though?
Well, the blind count's for controlled substances. You do it every time they remove it.
Okay.
And that'll tell you whether you've got an issue.
Yes.
But
You have a
remember, our
question,
systems are
Ricardo?
a replacement for e-kits.
We have fingerprint ID, BioID.
Was on. Is it a thumbprint?
Yes, it's a thumbprint.
Okay, so that's how you do your bio.
Yes.
Okay.
So, once again, in the system, it controls access to just that one medication and not multiple medications like you do with the tackle box. So the higher security for the facility and also for the pharmacy on that particular item. And then, as we just talked about, it also has the capability of requiring a witness, particularly if it's a scheduled med, you can require that, and authentication. So what we mean by authentication, there is the capability for the pharmacy to have to be called prior to the dispense of that item so they can make sure that that particular individual and that patient should get that particular med, and we do that through a PIN number. So that can also be part of the solution as well. So much
You
more
can also put in alerts like Pyxis does where it says, check your heart rate before you give this med.
Absolutely, you can put alerts in the system. So the point here is, compared to an open tackle box where I can get in and get anything else, this system requires you to go through a certain workflow and make sure that the pharmacy is on board with that workflow, which you don't get with the manual tackle box today. So, yes?
Is there a way to return the medication, again, in case of human error?
There is a way to return it, but you cannot return it back to that existing pocket. There's a specific return bin so it doesn't get cross-contamination. We eliminate that problem.
Okay, so whoever puts their thumbprint in, and if it's a human error, they can go and put it right into the
Exactly.
other bin.
So they have to log back into the system, go to a return function, and then it goes into a separate return bin that will then be cleared out later. Okay? So we call our system a closed loop system. So I'm going to get into a little bit of detail here because I think it ties to the security of the system. So the first step for a pharmacy technician is to restock these, what we call cubies or pockets. And so what happens is they'll go into the system, they log in through by ID identification, they would select the patient, they select the facility, they select the medication, and then they would actually stock the medication in the system, all the while tracking NDC, lot number, expiration date, etc. They'll generate a label that matches that medication. That label goes in the front of the QB system here. And then at that point, the QB then goes to step 2, is eligible for being inspected by a pharmacist. So pharmacists would also log in, going through bioidentification, log into the system, ask for that particular medication. The med drawer will open up, the lid pops, and they can then look inside, verify that this medication is the same medication that is on the label description on the front of the QB. And we have an electronic record of that. So unlike in a tackle box, I don't know if it was inspected or not inspected. In this case, I can guarantee whether it was inspected by a pharmacist or not, because their bio-ID thumbprint is attached to that approval of what's inside of this QB. So now that process is complete, the QB pops out, and then we go to step 3, which is the QB now goes into a secure tote. That tote is sealed, and then that tote is transported to the facility. Once it reaches the facility, then at this point, it is exchanged with an existing QB that is in the QBEX cabinet. So what happens is the user will then grab the scanner after they've logged in with their BioID. They'll grab the scanner, scan the barcode, and then the system will recognize, okay, that's medication A, and then that drawer for that medication will move forward. The existing QB that's in there will pop up. They'll take that one away, and they'll put the new QB. So they'll exchange the old QB with the new QB that's full of meds, and they'll put it back into that spot. So we now have electronic signature of who went in, what time, what did they go in for, and what they replaced. And then the other QB that came out is secure. You can't open it at that point. It's tamper evident if somebody does try and open it. And really the way you could open it is with a screwdriver, right? So at that point, it would be tamper evident. We'd know who went into it and who was responsible for it at the last moment.
And if it gets tampered in transit, it won't allow you to place the QB inside the machine.
It will reject it.
I'm just curious if it has any way of flagging the amount of prescriptions that are being put out. Say someone puts in 1,000 Oxycontins every week or something like that. Is there something that would notify the pharmacist that, hey, something's happening here?
Oh, absolutely.
Okay.
Yes.
I understand the security part of it, but patterns is
The pharmacist has access to all sorts of reports on
Right.
the back end that you can run high users, and we massage a lot of that data to identify diversion.
Yeah, we get a lot of cases where they take half the store.
Sure, absolutely. You'll be able to track that. I mean, that's the beauty of the system, is that electronic tracking of what's happening with the eKit and First Dose, where you don't have with a tackle box. So that's the other piece. I did
So
leave.
can I just have one
Yes.
question? Is there a way you could trick the system? Like, you scan the new QB, the old little thing pops up, you take it out, you put that one, let's say we're doing OxyContin, and that one has 3 OxyContin, my new one has 100. So I put the one with 3 back in, and I keep the one with 100 for me.
No, because there's a microchip on the bottom of this, and so it's expecting this QB to go in that spot.
Okay.
And it won't allow the old QB to go back in that same
Okay.
spot. Yeah.
And if it doesn't arrive, you know that it hasn't gotten there.
Absolutely. One of the things is if it's not restocked back into the system, we can notify the pharmacy that it hasn't been restocked in X period of time, and they could look at that and make sure that that gets restocked in a timely manner. So that's another way we can help drive compliance. I won't go through all the detail in the rest of the slides. It's really backup for what I shared with you earlier, but goes through it in step by step. I went through that with you verbally. I wanted to leave that for you in case you have questions later on that you want to refer back to. One of the key things I did neglect to mention is there is a little window on the QB. So not only does the pharmacist go into the system, we have their BioID that they went in and verified this, but we also have their signature on the QB. So anybody that's transporting this can also see, okay, this has been signed off by a pharmacist as well. So there's a double way of making sure that it has been screened by a pharmacist. I guess, this is not in my slides, but as I was listening to what's happening here this morning, I guess the big concern that is if the law changes, or the regs change so that a nurse can no longer restock or exchange the QB, the impact of that would be that pharmacies would be less likely to use automated dispensing systems. The challenge with that, as we that care about patient care, is today, as you know, there's 48 meds allowed in a tackle box. So you're going to drastically reduce the amount of meds that are available to the long-term care facility to take care of that patient, number one. Number two is you're going to continue to increase the risk related not only to patient safety, but full access of the medications, and also the risk associated with the staff members that are accessing those medications. So that's the concern about changing the regs. It's not so much as the ability to restock. As I walked you through it, it's pretty straightforward, and the system really guides you through the process. It's very simple to do. So the impact, though, is of changing it. It will definitely impact patient care, in our opinion, negatively, because you have less meds on site, and you also have more risk with the staff that access those meds. So I won't walk you through the regulation. You obviously know it well, but our request, again, is that we continue to allow pharmacy or nurse personnel in a long-term care facility to exchange the QBs, which are tamper evident, back into the system. Any questions?
So how many pharmacies at the skilled nursing facilities that you have that system
Yeah,
in
so
right
there's approximately 300 facilities that are utilizing these in the state of California. And as you know, there's 1,212 facilities in the state of California. So about, what's that, a quarter of the facilities are utilizing it today. That's of our system. And of course, there's other solutions in the marketplace similar to ours. So I would say, and this is a complete guess on my part, that there's probably over 500 facilities that are utilizing some sort of automation system related to First Dose and EKIT.
You give me a couple in the LA area, so I want to go and take a look at it.
Yeah, absolutely.
And I just caught that. So this is basically used just for the first dose.
Just used for First Dose and EKIT.
Follow-up doses are coming from a pharmacy.
Right, exactly. Any questions on this?
Are you including controlled substances in here?
We do. We do, and most pharmacies will send that in a separate tote from the non-narcotics.
And how many sites you've got in California that are up?
Over 300.
Okay, and have you identified any issues over, and how long has this been going on?
Well, the QB exchange process has been going on really since 2006 in any real size or form
So 10 years.
In California.
So in those 10 years, have you identified any issues with drug diversion with the QBs on controlled substances?
Not on controlled substances, we haven't noticed any diversion issues because of all the security I mentioned earlier. Our number one issue is really just working with pharmacies to understand I'm just speaking strictly selfishly on our side, to understand the return on investment. It hasn't been operational issues, hasn't been nurse training issues, hasn't been pharmacy training issues. It's really more, how do we get people to catch the vision? Yep. Any other questions on this? Exactly the same way as with the current tackle box solution, yes.
And this is also only for nurse-administered doses. So this isn't meds that the patient would access. This would be like if a nurse would go into a tackle box or a med room and grab a dose because they need it emergently for an SNF patient.
Yeah. Okay.
Good morning.
Sam, before we go into, do you have any board member questions before we move on to public comment?
I was just going to add that in addition to the security from Cubex, pharmacies also provide additional securities. As he was saying, the ongoing management of a perpetual inventory every time a drug is taken, controlled or non-controlled, most pharmacies require that inside the facilities. The delivery of that tote in a secure fashion so that it's tamper evident and the pickup of the used tote back in here with a different type of seal. So the pharmacies that are utilizing these automatic dispensing devices have tried to place additional controls beyond what the manufacturer offers to satisfy not only their internal requirements, but the facilities also want as secure a system as possible. The challenge that we heard earlier of 24/7 admissions of very ill patients to long-term care facilities is alive and well. These people come in pain, needing medications, and even though Title 22 requires the delivery of 1 hour or 4 hours, it's much better to get that medication in 10 or 15 minutes. Challenge is how to maintain this machine. And if the system is secure enough to allow the QB to be put back into the machine by someone other than, as the requirement is now, a pharmacy personnel, a technician, an intern, cameras over the machine. That's the core issue. In the time that I've been familiar with the use of these machines, the last 2 or 3 or 4 years, in my limited scope, I have not seen diversion. In my limited scope, I have not seen anybody taking a screwdriver to these machines. And the reason is because most of the time, in the QBs, the pharmacies place small quantities of drugs, 2, 3, 4 doses, because they know they're going to be able to replace them very quickly. If the requirement is that only licensed personnel be allowed, from pharmacies be allowed to do these, a possible unintended consequence might be that the pharmacy, instead of putting 3 doses of drug A into a QB, they'll put 30 doses of drug A into a QB. As we all know, the more temptation, the stronger, the more challenges there is to security. And that's also something that the board, and I congratulate the board in trying to get their arms around what is the technology, how can we adjust this for better patient care, and what improvements could be made by the companies that do the technology. At the end of the day, we're all here for the one thing, and that is providing good patient care. So, thank you. Thank you for your time.
Thank you.
Well, can I ask a question? As we were talking to the last person, so the delivery of the medication, I think the last one, it actually came from the wholesaler. In this case, it's coming, it's a delivery service from the pharmacy, to the SNF. Okay.
Correct. Yep.
Right, and this system has been in place in California for 11 years, and the process is that the pharmacy places the QBs into a secure tote. The tote is transferred to the nursing care facility. The manifest is signed for, and then the nurse puts away all the medications in that tote, including the QBs, into the QBEX system.
And so you're asking for
no change.
No change.
No change, okay.
Right.
So you wanted to continue to be the pharmacist or a nurse?
Correct.
Right.
And it's always it's a nurse, it's not...
It's always been a nurse,
Okay.
but there was a change, and the board had asked for pharmacy personnel. So we're asking to continue
Not changing.
having the nurse
Right.
do that.
Good. Thank you very much for your time.
And you stated that it
Dave
would be best to
Swenson.
have BD come up
Yeah, if
afterwards?
you don't
Okay.
mind, that'd be great.
Yes, since it's similar?
Yes.
Okay. Good morning. Good morning. Hi, Rodney. How are you?
Well, we're getting our presentation teed up here. We'll introduce ourselves. My name is Dave Swenson, pharmacist by background, and work with Becton Dickinson's Medication Management Division here in, down in San Diego. And I hope we can all get back to where we're going today.
Formerly known as CareFusion, or?
Formerly known as CareFusion, formerly known as Cardinal Health, and formerly known as Pyxis previous to that. So appreciate the opportunity to talk with you all today. And Anton, I want to thank Anton and the QBEX team for providing some very good background. We can build on that. It'll save us some time as we go through and talk about what we think is kind of a challenging area of medication management, and that's emergency medical providers and the medications they need there. We have some ideas for you around that using technology that we'd like to review. So,
sure. And I'd like to certainly thank you for the opportunity for us to present. My name is Rodney Chin. I'm a clinical consultant for BD Pyxis Pharmacists and for the Southern California area. So thank you.
Okay, well, what we want to do today, and click the next slide here for us, Rodney, and we'll, so we want to address your 2 questions that you put to the group, but within the context of talking about emergency medical provision of care in emergency situations. We'll talk about providing for consumer protection around that, using technology and some procedures built around that. And then we'll also talk about areas of pharmacy law that currently impede, and we'll go through both of those. So I'm going to spend most of my time on the next slide, so go ahead, Rodney, and I'm going to walk through this and kind of refer to various pieces as we go through. Now, emergency medical carriers or trucks or ambulances, if you will, have historically received their medication from a variety of places, not necessarily wholesalers, okay? But recently we've had discussions with a number of the providers who are no longer able to get the medications, acquire them in the same way they have previously because of changes in how those medications are monitored. So the prospect here is, should those medications come from a wholesaler? So I've got a wholesaler up here, but we'll talk more about that. So hypothetically speaking, under a new set of regulations, you would have a wholesaler deliver medications, if the law was changed to allow this, go ahead, Rodney, to a firehouse, for example. And in this scenario, what you would see is you would see those medications arrive. They'd be ordered in the conventional manner. And using the processes that Anton explained, they can be scanned into the perpetual inventory in a MedStation system on site. Now, I'll point something out here, though. If those medications were able to come from another acute care facility, we would have the opportunity to leverage that closed-loop QB system that you just heard Anton talk about, okay? So, but that's a structural change in how medications would be provided that the group would have to undertake and work with the EMT providers to see if that made sense.
So, kind of going back to the first guy, when they received their order from the wholesaler, he said, you know, it was kind of put into the machine, and then the machine would recognize, and a remote pharmacist then would kind of validate the order. Is that how this works also?
Well, I'm talking about really 2 different scenarios. In a conventional scenario, right now, these EMT providers are no longer able to go to hospitals, so the kind of the default method they would go through would be to go to a wholesaler. And that's why I've put wholesaler up here. Now, I'll talk about that scenario first. If a wholesaler, if the medications were ordered by the EMTs from a wholesaler, those medications would follow the conventional legal method to get them, and they would arrive then at the fire station, or in this case, and they would be scanned into inventory. And when they're scanned into inventory, they could go into a number of controlled storage devices. And go ahead. Well, you saw the QBs previously. I don't have to show you those, but they'd go into QBs. Okay. So that's one scenario. The other scenario would be is if instead of a wholesaler there, you had a facility like Anton and Cubex runs, where, or a hospital where the medication could be placed in secure QBs and then transferred in these secure QBs from that facility to the firehouse. So really there's 2 different options here in terms of how this could work.
Fully safe?
No. Having them run through, having the placed in a QB in a healthcare facility and transferred to a firehouse would be more secure.
I think the other thing I would like to add to what Dave just mentioned regarding the EMS is that, you know, the current situation is that often fire departments go to either the wholesalers or, more importantly, more often I see is they go to hospitals to have meds filled. So they go there with their manual inventory sheets and pick up the meds that they need. The challenge that you have currently, the gap in the law, is that basically the pharmacy director is licensed for that particular hospital. And so, you know, regarding the EMS and those fire departments, they really don't have a lot of, they don't have jurisdiction over those, but yet they're they have some liability because they're filling meds for that department. So that's why we sort of want the EMS to recommend that the board does consider some to address that gap.
But just in summary then, on this first step, 1 and 2 here, what we're talking about is there is an opportunity to leverage this secure storage QB method to supply the firehouses. Conventionally, otherwise, they could come from the wholesaler and then be scanned into inventory. If that is the case, there are methods of using audit reports to check to make sure what was ordered from the wholesaler was indeed scanned into inventory. So there is a method to do that, yes.
In a fire department situation, however, you have a very limited formulary, do you not?
Correct. It's typically less than like 30 formulary line items.
So there, the wholesaler would, and whoever's delivering would have a better chance of knowing, being familiar with the drugs, as opposed to a fully stocked machine that maybe has 100 or 200 different drugs in them.
Correct. That is exactly right.
We happen to be sponsoring legislation in this area. We're a little sensitive.
Okay, understand. So then continuing with our story here, once it is in the perpetual inventory in the firehouse, then you have ambulances that need to be stocked, okay? And conventionally how this is done is using totes, double lock totes that the ambulance use with medication stored in it. Again, to Ms. Harold's point, typically the formulary is very limited. It's in the 20 to 30 medication range, in addition, plus IVs and other solutions. That inventory would be securely signed out using biometric ID by the responsible person and checked into the inventory of the tackle box, or the double lock box that the truck would carry. And that's the conventional method that's used now. They use log sheets. We would suggest as a part of this that documentation be tightened up. One way to do this would be to have package-specific log sheets. So when you hand out a package, you hand out a log sheet with it. You sign it out until that particular package is gone, and in order to get another package, you surrender a filled-out log sheet. Something of that nature would provide a little more tightening of that process. Now, in the future, I would not rule out the possibility of having this dispensing process that happens on the EMT trucks be something that could be automated as well, using a miniature cabinet. We are looking at the possibility of what could be done there, so that this we recognize is not an ideal setting, but on the other hand, care needs to be provided in emergencies, and we realize that. So moving on, then care is delivered and the cycle then repeats. So I won't spend a lot of time on the following slides because I think Anton did a very nice job going through that, but I'll just highlight a couple of things that are supplementary. Go ahead to the next slide.
So in terms of the slide that you had with the workflow,
yes,
with controlled substances, this would be different.
Controlled substances would still be subject to the scanning. With controlled substances, as you heard the QBEX team talk about, there would be what we would recommend is blind counts that take place.
But this is different from QBEX because you're talking about a wholesaler delivering, right? QBEX was having the pharmacy supply it.
Right.
You're having a wholesaler deliver. So is a wholesaler delivering controlled substances?
I'm sorry, Amy. During the time, just a few minutes ago, we talked about two different methods for providing the medications to the firehouse. One being from a wholesaler, which would be the less secure, but what you would do, deliver it, scan it into inventory, verify the count, and then it would be a auditing process where you would compare what's delivered with what was scanned in inventory, and that would need to be done regularly.
That would still be for controlled substances, the wholesaler.
Yes, correct. So that's one method. The other method would be to have this come in secure QBs from another healthcare institution. Some EMTs in the past have certainly been supplied through hospitals. This would be a method that would allow the QB to be used there.
What about the use of the C2 safe?
C2 safe for large scale, I'm going to talk about that in a minute, for large scale operations would be a better solution than a Pyxis station. The reason I mentioned a Pyxis station, to Ms. Harold's previous point, is that the formulary is very limited. There's typically like 30 line items.
Okay, thank you.
Okay. So let's move on to the next slide. So BioID was discussed. I won't spend any time on that. We'll move on. One drawer type that was not mentioned during the QBEX team's review was what we call a mini drawer. And what the mini drawer does is it narrows the accessible medication to one dose at a time. So as you see here in the sequence, the 1 dose taken, 2 dose taken, it meters out and allows individual doses to be removed as eaches if you want that level of control. The MedStation system has that capability from Pyxis. And then QBs we talked about, won't spend much time with that. On from that one.
Just want to note that BD did redesign the QBs to even be more diversion proof by the development of the lid. It's a lid that goes around the Smart QB.
It just helps with tamper prevention. It's a more secure, and of course, was also mentioned already that these contain a microchip which has embedded in it the identity and quantity of the medication, which is very helpful in track and trace.
Pretty much the same as the Cubex one?
Yes. So Cubex, we are partners with Cubex, and we supply Cubex with hardware, and then they put with that hardware a software system that's specific to long-term care facilities and other similar types of care providing places. Okay. So one point I want to emphasize is Pyxis is in over 2,700 hospitals nationwide. And through this incorporation of more and more customers, our system has had to get more and more diverse in order to meet the state laws in each state, all 50 states, and in order to meet individual health system needs, which can vary. And because of that, it's highly configurable. And the fire stations in the workflow that we talked about can take advantage of this configurability to do things like blind count, to do things like require witnesses, to your point, Amy, previously about controlled drugs. Witnesses should be something that should be required in terms of the process with this. There can be methods to assure that any waste, if a product is opened and not used, you can have a double witness for a waste for those. Question?
Some uniformity with different cities and counties, as you know. Everybody's going to want a piece of this if it were to go with the firehouses. Do you have anything in Southern California, Northern California? Have you explored any of the fire?
Do we have installations in firehouses now? Yeah. We have a few, yes. The configuration of those varies quite a bit, and I think that would be great if the board could step in and create uniformity around this and assure that these systems are tight. I think in some cases there are places that could be a little tighter in terms of how they're managing these. So I won't go through all of this, but there is again a lot of configurability in terms of return bins, in terms of how the timeout for the system works, something you might not think about. Somebody gets distracted and walks away from this device. What does it do? Does it stay? Does it time that person out so that doesn't leave lingering access for someone else? A lot of different capabilities, no time to get into, but that is there, and we're certainly willing to explore it with you, and if you'd like to get more specific information.
And also just want to add under user privilege templates, I noticed in your questionnaire a lot spoke about security to ensure that there's secure user accessibility too, and a lot of it can be defined with user privileges and roles to ensure that that person has a particular user has access to only selected items, certain meds.
Okay, so we made the point on configurability. Well, the next point I wanted to make, and again, won't go into a lot of detail, you can change the screen here, is C2 Safe. The primary difference here is this is designed for predominantly controlled substances, for distribution to multi-points with controlled substances. So for example, take a large EMT operation like LA County Fire, where you've got a large number of firehouses and central distribution points. That would be a perfect case to use something like C2 Safe for the controlled drugs, and then they could be checked out in a very secure manner, logged out, and then it does what's called closed loop. You heard Anton talk about this previously, where if something leaves the C2 Safe, it is expected at its destination, and alerts go off if it's not received within a certain period of time in the correct quantity.
And to clarify this proposed workflow, we're talking about purchases that are being made typically in the fire department under a physician's DA license,
Correct.
not a pharmacy license.
Under a physician's license, that's exactly
The
right.
physician basically oversees. The only reason that I believe the Board of Pharmacy has a role is because they could be wholesalers. Is that right,
Correct.
Jenny?
Sorry, there is a model using a wholesaler.
And I'll talk more about that when we get in.
That is actually controlled, though, the permit is issued to the fire department for that wholesale permit.
So I just wanted to clarify that for the board members that are asking, where's the pharmacist? This is not under a licensed pharmacy model. It is through a physician's DEA number, who's typically the medical director of the fire department.
That's exactly right.
I had a question, too.
Yes.
At a time when everything's being hacked into, what safeguards do you put in where somebody can't just hack in and issue themselves all of these medications themselves?
That is a great and very timely question. And what we do internally, and this is throughout Becton Dickinson, is we hire what's called white hat hackers. And we hire people to try to invade into our system and then have us, and then report back to us on what they were able to do. This is not only with the Pyxis systems, but it's also with our infusion pumps. And we spend a lot of effort and time preventing those kinds of things from happening through cybersecurity that we put into the products. It's a very big deal for us.
Great models that we're hearing and stuff. I'm just curious about the hacking part.
I'm glad you asked. So I won't go into a lot on the reports. There was a question that came up earlier, though. I'll use that kind of to highlight something. It's, what if somebody were taking out a quantity that was abnormal? There's a series of reports in the system that allow administrators to set an average amount that the users take out of the system and then identify users that take out over 2 standard deviations above that. So there is monitoring capabilities that get quite sophisticated. That's one example of that. I won't go through the rest, but there's a lot of matching and auditing that will go into this. But it's essentially a chain of custody, where from one location to the next, you have a chain of custody where you can audit and verify that the complete quantity goes through that.
So Jenny, part of this, there's a bill that's pending, so some of this will be flushed out in the bill.
Right, we're the sponsor of the bill. It's a Senator Hernandez bill, and it just went into print yesterday. I don't remember the bill number.
So a lot of this will be probably through.
Excellent. We're looking forward to seeing that. We've been visited by a number of providers who are very interested in knowing how to do this right, and so that
I know that LA County is one of them that actually is doing it, and we're a very big proponent of having a pharmacist kind of be the expert on reviewing it, because a lot of times they know what they're doing more so than some of the medical staff on how to manage this.
Totally agree.
The whole distribution process.
They have sought advice from pharmacy experts on automation, and I know budgets won't permit all of them to have that type of capability on staff, but certainly consultants could help them there.
Authorize a practice that's already occurring out there in a manner that's safe, because right now there is no authority for that to be going on, and we want to continue to support this kind of thing, but you can't have it going on without the law regulating it. We've got a lot of drugs going everywhere right now.
Well, I think standardization is exactly right. If there's an approved method that can be audited and people know what to do, I think the vast majority are going to migrate right towards that. So let's keep going here.
I think we're almost out of time, so if you can complete.
So just, I'll skip over the federal. HR 304 is going through the process. I'm sure you're all aware of that. EMS staging facilities are not part of the law as it stands now, to my understanding, and that's really would be our main suggestion in terms of making a provision, and I know you are, in the law to allow those facilities to be incorporated. And then the last piece here I'll mention is the pharmacy oversight. You know, it is out of financial, it's not realistically possible for many of these fire departments to have a pharmacist on staff, but it certainly is possible to have pharmacists as consultants who come in and sign off on what they're doing in a similar fashion that's done for long-term care facilities, really, where they come in and sign off. What we've got.
So you service more than, in your questionnaire is acute care systems, ambulatory nursing, LTCs.
Those are
But you kind of
environments.
focused your comments, seems like, more on the emergency
Right.
services.
Those other environments that you just mentioned, Pyxis is used, and there are defined processes in most of those environments. What Anton was mentioning, kind of an exception, but most of them have processes that are pretty defined. This is an area that I know is in current dialogue and discussion. We wanted to provide some background and also express our willingness to help through innovation identify solutions that can help.
Yeah, and I'm going to follow up in Debbie's comment. The other environments, the restocking methodology is similar to the QB or QBEX, where the pharmacy stocks the QB and it's delivered to the nursing unit or the SNF.
Secure transport is preferred, if we can do it.
And so have you had, because it looks like in your comments, like what law changes would you like for us to make? It seems like it's around, the emergency program. And so have you had a chance to look at what Ms. Harold was referencing? And did you
I have not. I didn't know it was released. If it is, I'd love to see it. Okay.
I'll fund the bill number.
Okay.
443? Someone knows.
Good.
443. Thank you.
Thank you all.
Thank you. All right, moving, do you want to take a short break? Okay, let's take a 10-minute bio break and be back here at 11:10.